This conference will now be recorded.
So we can see the first slide. We can show the next slide. Yeah. Okay. Yeah, we had this patient about a month ago. A young male, non-smoker, came to the OPD with fever, abdominal pain, and bloody dysentery. He had large bowel diarrhea mixed with blood and stools, and he had generalized weakness, nodules in the skin, on the legs, and about 8 kg weight loss over 1 year. And he also gave history of recurrent loose motions. Evaluation, this is evaluation. So what is abnormal in this? Can you tell me what are the abnormal in this and what is the diagnosis? You can type here. Type. So where's the chat box? Yeah, you can type the answer in this or the abnormality in this. Let's go to the next slide. Yeah, I need you to respond. If you are hearing, say yes and type the abnormality here. Okay, let it be interactive. And you can get all the slides. So if you are hearing me, say yes. Okay, somebody is responding, but what is the abnormality here? Just tell me. Somebody can type what are the abnormality. Yeah, somebody, Kavyani correctly said, Mane has given the diagnosis. Very good, very good. Mahima has given the diagnosis, and Ashwant Reddy, Shreya, all have given the diagnosis, but you have not given me the abnormal lab test. It could be even anemic dysentery, right? So what is the evidence for IBD? So Sree also has this one, about 20 of you have interacted. So let us see, it is inflammatory bowel disease, and it has got two components or two types, which is mainly Crohn's disease and ulcerative colitis. You would have read in pathology, what is the main difference between them? Between ulcerative colitis and Crohn's? What are the major differences? Can you tell me? Major difference between ulcerative colitis and Crohn's disease. You can type there. Yeah, once somebody said location, yeah. Second, extra-intestinal complications are more rare. Extra-intestinal complications are more rare. Okay. Where you get more fistulas, and which is associated with HLA-B27. Very good, excellent. So ulcerate, there is a clue in the figure itself. See the location of the lesions. You can make out the difference. Okay, and certain parts of the world, some is common, certain parts of the world, some other is common. It's an autoimmune disease. So let us see something about it. So inflammatory bowel disease are a group of intestinal disorders that causes inflammation of the digestive tract, and the spectrum may be very, very mild to life-threatening infection. Okay, it's basically an autoimmune disease. Okay, so it's an autoimmune disease, and the that is that. Okay, so I need this slide show. Yeah, so we have seen these things, and so as we know that they are divided into Crohn's disease and ulcerative colitis. depending upon the type of lesion, site of lesion, nature of lesion, response to treatment, genetic association, and all that. Okay, so that is another important point. Okay, so mainly if it's involved the gut, large gut is ulcerative colitis, and Crohn's it will be the small intestine, but it can occur anywhere. And Crohn's there is a large amount of extra intestinal manifestation. And this cartoon gives an example of the various diseases. And in Crohn's, it's ulceration within the mucosa, and in ulcerative colitis, while in Crohn's you have muscle hypertrophy, fissures, cobblestone appearance, and it's a skip lesions are found there. Okay, so it's not very uncommon, and there are various causes for it, but it's widely prevalent more in the Western countries and not much here. The exact cause we do not know, but it's some autoimmune disease, and the incidence varies depending upon the modality of evaluation. Various infectious agents have been implicated, certain environmental factors, but what is important is stress is another important thing which will precipitate IBD. So if a person is stressed out, we have a flare of the disease. It may not be causing it, but it can flare. Okay. And basically what causes it, just remember two things, it's an autoimmune disease. So some antigen, there is a over immune response because of the activation of the immune system, and there is a inflammatory cytokine surge which occurs, mainly mediated by CD4 cells, T cells, and B cells. Okay, so what happens is, this will give a huge cartoon of various mediators which you don't have to remember, but all you have to remember is that an entire gamut of cells and cytokines are involved. So we have seen about the etiology, we have seen the pathophysiology. Now we come to the clinical manifestation. Clinical manifestation can be very varied. They can have only abdominal pain and diarrhea off and on in a young male, or they can be having full systemic manifestations in the form of fever, weight loss, decreased appetite, prostration, severe dysentery, and dehydration, and all that. So it can occur in a wide variety of manner. Sometimes they will present only with extra-articular manifestation in the form of asymmetric oligoarthritis or erythema nodosum or uveitis. So eye may be involved, skin may be involved, or the joints may be involved. So how do we diagnose? Diagnosis mainly by history taking and certain tests which you can make out that is got inflammatory bowel disease. Nowadays we have the fecal calprotectin, which is very specific for the inflammation, and if you can do an endoscopic biopsy or a colonic biopsy, mucosa, which shows that evidence of inflammation. Radiology may help in certain cases, which shows serrations and irregular mucosal surface, and biopsy is usually diagnostic. And we also need to remember that in tropical countries like India, we need to rule out other infections like cryptosporidiosis, your CMA disease, and your amoebic dysentery, giardiasis, and abdominal tuberculosis. They are all mimickers of IgD. Okay, so what I have seen, we have seen what is it, or the clinical profile, what is the etiology, what is the pathology, and what are the clinical features. Okay, what is the treatment? Can somebody tell me, apart from steroids, you can type it. What is the treatment? Yeah. So if can somebody tell the treatment? And I also given you the slides showing the tabulated difference. Okay, so you can just see the difference between Crohn's and ulcerative. Okay, so but many times it can be mixed. Okay, it's not absolute that fistula has to be there, but sometimes it's more common. For example, fistulas are more common in Crohn's, while in ulcerative it is less common. Okay, perianal involvement very common in Crohn's. Rectal involvement more common in ulcerative. Okay, so that is the snapshot view of the various differences. This you can note it down and that you can differentiate, but treatment remains the same. So can you just type out what is the treatment for it? Because it's an autoimmune disease. What all can be given? Autoimmune disease. So you have to reduce the immune inflammation. Yeah. So somebody has correctly said, Shankar said correct dehydration, immunosuppressive therapy. What? Yeah, and Sree has correctly said TNF alpha inhibitors. Can you name some? Can you name some TNF alpha inhibitors, Sree, which is used in the treatment of ulcerative colitis? Somebody said antibiotics, of course it will help. Biological agents, corticosteroids, azathioprine, MMF. Which biological agents? Can you tell me which TNF agents are useful? Kevin has correctly said it's infliximab. Infliximab is a human most chimeric monoclonal antibody which acts against TNF alpha. It's not a receptor blocker, it's a direct TNF neutralizing monoclonal antibody. So you can have not transituzumab, it is only infliximab, adalimumab, and golimumab and ceftolimab. So you can write it down: infliximab, adalimumab, golimumab, and ceftolimab. They are all powerful TNF blocking agents. Etanercept does not work. Okay. So that is the this one, goals and all not required. Yeah, just remember this slide. This will give a snapshot view of all the important treatment modalities. Okay, so that is yeah, that will be the treatment modalities which are very common. So initially with antibiotics and sulfasalazine, 5-ASA, aminosulfosalic acid, it's used for local therapy. We can give steroid enema, IV steroids, oral steroids, and we can give immunomodulators like azathioprine and methotrexate. But if it doesn't work nowadays for severe disease, we definitely going for an anti-TNF agent. But before giving anti-TNF agent, we have to vaccinate because it can cause tuberculosis and it's very expensive. For example, methotrexate costs 9 rupees. Well, infliximab, 1 vial costs 40,000 rupees, and we have to give 3 vials and about 18 vials. So you can imagine it makes you go down by 5 to 6 lakhs. So it can be very expensive. So what we do is we give an initial course of steroids and then start him on azathioprine. And in certain cases, surgery will help. If there's extensive inflammation, we can go for surgery. Okay. So that is that. Okay. I'll not go into the detail that you can read it, but what is important is just remember this. This is the various anti-TNF available in India. Adalimumab costs around 15,000. Infliximab and Remicade costs around 40,000. Symphony costs around a lakh per injection. So they're all very costly. So we can always give azathioprine, which is a cheaper alternative. Okay. So we have come with what all we have done. Just recapitulate. We saw the clinical profile of the patient. Number 2 is we saw what is it, then why is it, then is it where all is it involved, how is it, then how do you investigate, and how do you treat? Okay, so we have finished an overview of all the medical management. Now we go into the surgical management. Surgical management is very, very severe cases. When there is a toxic colitis with recurrent sepsis not responding to medicine, we have to give protocolectomy or restorative protocolectomy. Basically, you remove this inflamed segment. Sorry, it's an involved segment of the intestine. But even that is fraught with a lot of dangers. You can have sepsis, you can have fistulas. Okay. So, okay, I have finished. If there is anything else, you can tell me. If you have any doubt, you can just type it. I will do everything and answer it. Okay? Yeah. Cool. Any other doubt you have? Priyanka, Pinaki, Tejal, any other doubt? You can take the slides and you can, if there is any doubt, you can always give it to me. So you can get three types of short notes: management of ulcerative colitis, clinical features of ulcerative colitis, then pathophysiology and etiopathogenesis and treatment of ulcerative colitis, medical management of ulcerative colitis. So some common drugs we can discuss and then we can see it. Okay, what about others? Only Sree and Priyanka has responded. Others, any doubt is there? You can just respond.
Nice.
Okay.
Thank you, sir.